Good morning and welcome to our webinar. My name is Angel Casillas Carmona, and I am the project manager for the National Hispanic and Latino Mental Health Technology Transfer Center. For us, it's a pleasure to have you with us today for this virtual conference, Mental Health and COVID, Disparities, Strengths, and Global Perspectives. We will be detailing a little bit more about these topics through our presentation, and we will be focusing on Hispanic and Latino communities. To talk a little bit more about our center, we are based out of Puerto Rico and we are at Bayamón in Universidad Central del Caribe. We are part of a larger network of technology transfer centers. We are comprised of 10 regional centers and 2 national focus areas, of which ones we are one. The role of the National Hispanic and Latino is to provide training and technical assistance to providers that serve Hispanic and Latino populations in order for them to provide more effective treatment, implementing evidence-based and promoting practices. We also have a school-based mental health project in which we create awareness on the importance of school-based mental health services that are culturally appropriate and provide strategies on how to effectively implement culturally mental health services for the Hispanic and Latino youth. We create and disseminate different products. You can access them through our webpage or through our social media, so you can follow us on them. This is our information where you can access all these products and other webinars like this one. Today, we are having a great collaboration with Boston University and the Nicaragua University. And the Boston University has helped us to provide CEUs, and you can access them once the presentation is over through this evaluation that we're going to provide you with the link again after the presentation has ended. Once you complete this evaluation, you will be entitled to receiving the CEUs for this virtual conference. Also, a quick reminder to our participants, we are recording this presentation so you can access it after the webinar ends through our webpage as also. Now, I would like to share with you some words by our co-sponsors from the University of Boston. With us now, Dindelba. Dindelba, thank you for being with us today.
Muchas gracias por invitarnos, Ángel. Buenos días, good morning. As Dean of the Boston University School of Social Work and Director of the Center for Innovation in Social Work and Health, it's my deep privilege to invite you to today's event. We appreciate our collaboration with the National Hispanic and Latino Mental Health Technology Transfer Center Network and the National Autonomous University Regional Multidisciplinary Faculty in Estelí, Nicaragua, for hosting and making this virtual conference possible. We celebrate social work months around the world, and our role is essential in providing support and advocacy to address the impact of COVID-19 in all our lives. Thanks to the 1948 United Nations Universal Declaration of Human Rights, we are aware of rights in many spheres, including health and education. The COVID-19 pandemic has highlighted already existing inequities and disparities in health. Families in the United States and globally have been seriously affected by the loss of lives, social disruptions, economic challenges, and the mental health stressors of this pandemic. At the same time, we have witnessed community efforts, strength, and resilience in fighting the pandemic. This conference provides an opportunity to bring us together to address these issues and share culturally specific resources for clinicians, providers, faculty, and students. We want all families and individuals to be safe and protected from COVID-19 and to heal from the physical and mental health consequences of this pandemic. Our Center for Innovation in Social Work and Health is committed to continue advancing health equity and to eliminate racial and social injustices. Our mission is to expand the impact of social work in health and public health to improve the health and well-being of populations nationally and globally. This mission has become more visibly urgent during this COVID-19 pandemic. I want to truly thank you, each one of you, for being here and contributing to these efforts. I wish you a wonderful conference. Y ahora tengo el placer de presentarles a la decana Aracelis Barreda de la Universidad Nacional Autónoma de Nicaragua, Estelí. Que tengan un buen día.
Buenos días a todos y todas. Reciban un caluroso saludo desde Estelí, Nicaragua, desde la Universidad Nacional Autónoma de Nicaragua, especialmente desde nuestra Facultad Regional Multidisciplinaria FAREN Estelí. Es un honor para nosotros saludarles. Doctor Hanner Hernández, Universidad Central del Caribe, Cindy Love Negro Matos. Ángel Casillas, doctor Jorge Delva, decano de la Universidad de Boston, Escuela de Trabajo Social. Doctora Luz López, Universidad de Boston, Escuela de Trabajo Social. Maestra Tania Libertad Pérez, maestra Linet Ordóñez y maestra Liana Lanusa de la Universidad Autónoma de Nicaragua, UNAM Managua, FAREN Estelí. Este foro muestra el trabajo arduo que hemos realizado para adaptarnos a un nuevo contexto, teniendo como centro la salud mental. Según datos de la Organización Mundial de la Salud, OMS, la salud mental es una de las áreas más desatendidas de la salud pública. Cerca de 1.000 millones de personas viven con un trastorno mental y relativamente pocas personas en todo el mundo tienen acceso a servicios de salud mental de calidad. La pandemia COVID-19 ha dejado repercusiones adicionales en la salud mental de las personas en el mundo entero. Como academia tenemos el compromiso social de aportar a contrarrestar esta situación. Es por eso que como facultad desde la Clínica Psicosocial y Comunitaria impulsamos una campaña de atención a la salud mental para ayudar a la comunidad a entender esta pandemia y tomar medidas concretas a favor de nuestra propia salud mental. Estamos agradecidos por esta oportunidad de cooperación en la que compartimos experiencias desde diferentes contextos y donde en conjunto nos preparamos para asumir una serie de retos de importancia consonantes con la realidad de hoy frente al COVID-19, para lo cual tenemos que proporcionar acciones válidas y profundamente comprometidas con el ser humano en el espíritu de nuestra misión. Estamos anuentes a continuar con estos lazos de cooperación y amistad entre la Universidad de Boston y la Universidad Central del Caribe, reafirmando el compromiso social que nos une, velando por los demás. Les deseo éxito y que esta mañana sea de mucho provecho. Les dejo con Ángel Casilla.
I'm going to translate for her. So, good morning to all of you. Receive a warm greetings from Nicaragua and from UNAM Managua and the faculty FAREN Estelí. It's an honor to greet all of you, students and teachers connected to this platform. You are welcome. This forum shows the hard work we have done to adapt a new context with mental health as it occurs. According to data from the WHO, mental health is one of the most neglected areas of public health. Nearly 1 billion people are living with mental disorder, and relatively few people worldwide have access to quality mental health service. The COVID-19 pandemic has left additional repercussions on the mental health of people around the world. As an academy, we have the social commitment to contribute to counter this situation. That's why the faculty from the psychological social community clinic we promote a campaign of attention of mental health for our community, not just our students and also surrounding. This pandemic we had concrete measures in favor to our own health, mental health. We are grateful for this opportunity of cooperation, and we share experiences from different contexts. And we are together here to prepare and take series of important challenges in the reality we are living today. We have to provide valid actions and deeply commitment in the spirit of our missions. We are eager to continue with these ties of cooperation and friendship between Boston University and American Central del Caribe or Caribbean, reaffirming the social commitment that unite us, looking out for others. I wish you a lot of success and may this morning be very profitable. And Ángel?
Thank you, Leana, and gracias, Decana, por esas excelentes y hermosas palabras. Indeed, I make echo of the words of both deans that we, as institutional organizations on education, we should have a social commitment to provide better services to all the communities, even more now than ever that we have been now faced with the COVID-19 pandemic. So thank you all for leveraging our resources to be here today. Before we continue with our first presentation, I would like to speak a little bit more about what is our intention, our vision, and language for us is very important. And languages reflects the way that we treat people and the way that we provide services as clinicians. So the MHCTC network uses affirmative, respectful, and recovery-oriented language in all of its activities. So this is the type of language that you will continue to hear throughout our presentations and all of the materials that we develop. And this language is mostly identified by being non-judgmental and avoiding assumptions and focusing on the strengths and based on the hopes. As I mentioned, we are a SAMHSA grantees, and we provide all of these services free of charge thanks to these grants. So this is also why we ask you to provide with the evaluation so we can continue to provide these services free of charge. And this disclaimer means that although we are SAMHSA funded, SAMHSA does not by any means mean that they are behind the creation of this presentation, and it reflects only the voices and opinions of our center and the speakers. Today, our first presentation will be by one of our longtime collaborators, and is Dr. Hannah Hernandez, who will be discussing the presentation of COVID disparities, discriminations, and mental health challenges. Hannah has been a long time advocate of culturally sensitive treatment, and we are very glad to have him with us today in a few minutes. Before his presentation, I would like for us to move with another part that is important for the CEUs, and is the pre-test or the questions for the pre in terms of this first presentation. We will provide you with the questions for each of the presentations before them, and after the virtual conference is over, you will be able to access the questions through an email we'll be sending. So Cindy, could you help us with the questions?
Yes, good morning, everybody. I'm gonna go ahead and start the pre-test. Our first question reads, Latinx and African American communities are disproportionately affected by COVID pandemic due to, and you have a couple of options: higher rates of in-person essential jobs, more likely to live in urban communities with less social, less access to healthcare, higher incidence of diabetes, heart disease, and lung disease, or all of the above.
Se cayó.
Sorry, my microphone was off and I was reading the question, so I'll just read it again just in case it will help some people. Social determinants of health that contribute to racial and ethnic disparities with the COVID-19 pandemic are, and once again, you have to choose one of the options you have, either neighborhood environment, income, economic status, education, B and C, or all of the above. B and C being income, economic status, and education. Our next question says, cultural concepts of distress refers to, and once again, you have a couple of options, ways that cultural groups experience emotions, how people express and communicate their emotions, A and B, or none of the above. Our next question says, social disruptions due to COVID-19 results in higher level of stress and can create conflict and marital relationships. And it's a true or false question. The next one reads, in the past 6 months, due to COVID-19, mental health challenges have been, and you have a couple of options, social isolation, meaning not seeing family and friends, loss of employment, fear of being infected with COVID-19, missing weddings or other family events, or all of the above. Our last question for this portion says, ethnic groups like Asians or Latinos have suffered more discrimination during the pandemic. Once again, this is a true or false question.
Thank you, Cindy, for helping us. Now with us, Hannah Hernandez, who will be presenting the first presentation for today's virtual conference. We'll be starting in just a second. Hannah, can you hear me? Welcome.
You can see it. Can you see my screen, Angel?
Hello, Hannah, welcome. Yes,
Hi.
hi, nice to see you.
Nice to see you. Can you see my screen?
Yes, yes, we can see it.
Okay, thank you very much. Is it okay to get started?
Yes, whenever you're ready. We're right on.
Perfect. Well, I want to thank you very much for attending. I'm a long time, as Angel said, long-time collaborator, trainer, consultant with the National Latino Mental Health TTC. And I also want to recognize the folks from BU and to thank you also for the opportunity to collaborate. It's good to see familiar faces. Y le quiero dar las gracias a la gente de Nicaragua, a las compañeras, a la decana de Nicaragua. Es un placer escucharlas y saber que en Nicaragua se está haciendo un trabajo fenómeno con relación a issues de salud mental y adicciones. Tuve la oportunidad de estar en Nicaragua hace un par de años atrás, conocer de su labor y aprender y enseñar un poquito cuando estuve por allá. Así es que muchas gracias y bienvenida, bienvenido. So the topic that I have for today is disparities, discrimination, and mental health challenges within the context of COVID-19. Before I get to that, I just want to say a little bit more about myself. I've worked in the field of health and human services for the last 33 and a half years. I've worked primarily with a focus on substance use disorders and mental health challenges. And I've worked in residential outpatient settings, that sort of thing. I am a master trainer in a number of areas. And currently I run a program that trains Latino, Hispanic, or Latinx people who want to become certified or licensed drug and alcohol counselors in the state of Massachusetts. If people are interested in learning more about that, you see my contact information here. And I serve as a clinical supervisor on a number of local medication-assisted treatment programs here with a community health center and a local hospital in the emergency department. And so in addition to that, my work with the Mental Health TTC and other organizations at the national level takes me across the US doing work on the ground, learning from communities and organizations. You can note that I have more letters after my name than letters in my name. I want to tell you something that is important for me by way of context, is that I have a PhD, but I also have a GED. And my GED I got in prison. It was more difficult to get a GED in prison than to get a PhD out here. I am a person in long-term recovery from substance use disorder. And what that means for me is that I haven't used a drug, including alcohol, for the last 34 and a half years. What that enables me to do is to be a productive member, first and foremost, of my familia, my community, comunidad, and to be able to do this type of work. So coming at this presentation today, I am going to share with you data, information, research that has been done in this regard. But I'm also going to share some personal experience and information that comes from decades of doing this work. So without further ado, I'm going to move forward. I also want to let you know that you'll hear me use the terms Hispanic, Latino, Latinx, Latina interchangeably. There is no one way of using that depending on who you're speaking with. So when you hear me doing that, just know that different people identify in many different ways. Angel talked about the mental health TTC, and you see the map here. We encourage you to connect with the different TTCs, not just the mental health ones, but their addiction TTCs and prevention TTCs across the country. And Angel talked about the need for us to approach this work with the right type of language, being person-centered and non-judgmental. The one thing that I'll add to that is that language is a difficult thing to change. And for years in the US, people have used language that is stigmatizing and not helpful for this type of work. And so if you find yourself still using some of those words that might be in that realm of not appropriate, don't beat yourself up. Recognize that there will be moments in time where people have lapses in language, and then we should work to rectify those. We should begin with grounding the conversation on what disparities are and what they mean. And so according to Healthy People 2020, disparities are a racial, ethnic, or behavioral health outcome that is seen to a greater or lesser extent between populations. And we know that this is particularly linked with social, economic, and or environmental disadvantage. They have been developing on this country, on this continent, and here in the US for hundreds of years. So we should understand that, because that helps us to understand what we need to do moving forward. Disparities didn't develop on their own. Disparities have been created by intentional policies that contribute to inequities on the ground. This has produced institutionalized racism and other forms of oppression. And we should always understand that people, particularly poor people, marginalized people, so-called people of color, didn't create disparities. We have been on the receiving end of disparities. We did not create them. And furthermore, we should understand that COVID-19 exposed disparities, right? And so the impact of COVID-19 on marginalized communities, we're going to talk more about that. But the disparities were here and have been here for hundreds of years. In the US particularly, there has been sort of this focus on mental health, substance use disorders, and other diseases. And if you're listening closely to sort of the rhetoric and the debate, you will soon notice that there are a lot of people talking about personal responsibility. And there are many of us who have been advocating so that we focus on the societal determinants of health. And it's not that we don't want to focus on personal responsibility, but that very term has been used to stigmatize and put the onus primarily on individuals, with things that people go around saying like, if you really want to change, you can change. If you're more like Hanir, right, in terms of being a person in recovery, they point to people like me or to other people, and they hold us up in this light and saying, if you're more like these folks who did it, you can do it too. There's nothing that's stopping you from doing it. And we know that the societal determinants of health, and by the way, we're moving away from the social determinants of health terminology to more societal, because the social determinants of health imply that they're social only, and there are social aspects to it, but there are policies and laws that have been enacted in this country that contribute to disparities and that maintain disparities. And so we know that the societal determinants of health include economic stability, healthcare, neighborhood and environment, those conditions on the ground, the conditions related to education, social, community context, and others, right? And so this whole idea of rugged individualism and pull yourself up by the bootstrap mentality doesn't take into account regulation standards and other things that are in play. So as we move through this conversation today, you'll hear me come back to this interplay between the need for personal responsibility or to focus on the social determinants of health, or how do we do both in a balanced way? The COVID-19 context in the US, I know that most, if not all of you know this, but it's important just to review them. Over 29 people have been infected thus far in the US, and over 525,000 people have died. When I was updating this presentation, I remember doing a presentation in the summer where I took some of this data, and it was 60,000 people who had died, and it was only July. And there were 1 million people that we knew of were infected. So when I updated these numbers, I went like, oh, wow, how things have changed, right? We know that COVID-19 is a major psychological stressor for the entire population. And we know that it has disproportionate impacts on marginalized individuals, families, and communities, wreaking havoc across the country. And we're only seeing the tip of the iceberg of what this means for people on the ground moving forward. We know that Native people, Black, African Americans, Hispanic, Latinx folks, and those who are economically disadvantaged, including poor whites, continue to be disproportionately impacted, right? We know that by way of the context. We know that in terms of hospitalizations, American Indian or Alaska Native people, in terms of hospitalization rates, those rates are about 5.3 times that of non-Hispanic whites. They have the largest rate of hospitalizations at 5.3. When it comes to Black or Hispanic folk, we're about 4.7 times the rate of non-Hispanic white people in the country. Again, we can see very specifically disparities, and this didn't happen overnight. In terms of deaths, and it just breaks my heart to look at these data, because I know that these data, when we talk about numbers, they represent families, they represent individuals, they represent human beings who have died. And so for Indigenous Americans, 1 in 390 have died. For Black Americans, 1 in 555. For Pacific Islanders, 1 in 565. For white Americans, 1 in 665. You see Latinos come in at 1 in 680. And for Asian Americans, 1 in 1,040. Again, I don't want to minimize these numbers, because when we talk numbers, we lose sight that these are individuals, families, that these are communities, and entire groups of people who have been devastated, while these issues have been politicized and people continue to negate that this is a reality on the ground. And that sort of those sorts of attitudes, beliefs, and behaviors contribute to more people getting infected, more people dying, and the stigmatization that comes with these issues. The fact that Asian Americans have the lowest rate of deaths in the US does not negate the fact that very early on and throughout this pandemic, Asian Americans have been accused of being responsible for propagating the virus. And there are a number of news stories that talk about increased attacks on the Asian American community here in the United States. In terms of additional disparities and how this public health system works, and vaccine availability and access, we know that availability has been an issue for all of the states. We know that that's an issue, right? And we know that that continues to be an issue worldwide, because we know that several poor countries haven't even had access to one vaccine, never mind being able to vaccinate their folks. Here in the US, it should be noted that 2 of the wealthiest zip codes in Florida, by the way, have received priority access to vaccines. These are some of the same folk who are going around saying that COVID-19 is a hoax, and that we don't need to be concerned about using masks, and that we don't need to be concerned about this issue because it'll go away. But soon as vaccines came out, they were put at the front of the line. Native American, Native people, African American, Black folk, Hispanic, Latino folks have not been prioritized in the US. We have not been prioritized. And what we get is a public health system and infrastructure that once again fails to reach and engage marginalized communities. It once again fails to reach and engage marginalized communities in significant ways. This doesn't mean that some of our folks haven't gotten vaccinated. I have received the first dose of the vaccine myself, but I know countless individuals who qualify, who are interested in becoming vaccinated, and those are not yet available for them. And they are some of the most vulnerable people in the US, right? Moving towards this context on mental health and substance use disorders, I want to share some data with you quickly here. We know that about 46 million people in the US in 2017, that's nearly 1 in 5, live with a mental illness. We know that that is a fact. We know that serious mental illness is defined as a mental, behavior, or emotional disorder resulting in serious functional impairment, right? So we see that on a daily basis. And research has indicated that people with serious mental illness die 15 to 25 years earlier than the general population. When you think about disparities, think about who's impacted and who dies, who gets treatment, who doesn't, right? Those sorts of things in the United States. The term comorbidity, that some people call co-occurring, describes 2 or more disorders or illnesses occurring at the same time in the same person, right? And so in addition to mental health, some people have mental health and substance use disorders, and some people have physical health issues going on for them. And this complicates how and when people have access. It complicates how they're treated. It complicates if and when they get better. In 2018, approximately 20 million people over the age of 12 had a substance use disorder. And we should know that in terms of this number of people, a very small sliver of these folks, about 10%, actually get treatment in the United States. According to NIDA, people with substance use disorders may be particularly vulnerable to COVID-19 and its most adverse health outcomes, right? And so if we look at what has happened in 2020, over this last year, relapses, also known as reoccurrences, people picking up substances again, have skyrocketed. There are reports of this happening all over the country. And in my circles, and I live here in Massachusetts, and the people that I speak with across the country are all reporting huge relapse rates amongst the people that we serve, because recovery is social, right? We do recovery with other people. And COVID-19 forced us to go virtual. It forced programs to close. It forced recovery support centers to close. It forced groups where people went to receive and provide recovery supports to close. And many of our folk did not get access through virtual platforms because they don't possess the skills, the knowledge, or the technology, or the internet bandwidth to be able to participate in those types of recovery support. So things have gotten really dire for our folks on the ground. And this next set of data helps to prove that and shed light. COVID-19 has overshadowed the opioid crisis in the United States. And over a 12-month period last year, 82,000 people died. This is the largest number ever recorded of opioid overdose deaths in a 12-month period. That should be alarming because this is continuing to happen. And we know that prior to COVID-19, people of color, Blacks, Latinos, Native Americans, and others have been disproportionately impacted by issues of COVID, by issues of the opioid crisis, I should say. More around the connection between mental health, substance use disorders, and suicidal ideation during COVID-19. We have elevated levels of adverse mental health conditions, such as substance use and suicidal ideation. And these were reported in June of 2020. So they've gone up. The prevalence of symptoms of anxiety disorder was approximately 3 times those reported in the second quarter of 2019. So you see, right, anxiety and symptoms going up. And the prevalence of depressive disorder was approximately 4 times that reported in the second quarter of 2019. This gives us an idea of what's happening on the ground as it relates to COVID and suicidal ideation. I would be remiss if I don't mention that Latina girls specifically have disproportionate rates of suicidal ideation and attempts in the United States. It's something to think more about and to incorporate into our practices. Impacts on healthcare workers and behavioral health workers, right? There have been huge impacts. I think that the news media and reports have done a really good job to report on the impacts on healthcare workers. But we don't hear a lot on the impacts on the behavioral health workforce, who's also in the front line of treating people with substance use and mental health disorders. Countless people have been exposed to COVID-19, and many have died as a result. Many have died as a result. And so, you know, this is something to be concerned about, because right now, as the numbers are stabilizing in some places, going down in others, there's this sort of belief that COVID is going away and we don't need to pay attention to this anymore. As a matter of fact, some states are fully opening up and taking away protections, public health guidelines, and protections that help the population move forward. There are stressors associated with caring for the sick and or gravely ill under adverse circumstances. Imagine what that looks like, right? Being there for people when they're dying, being there for people when they're sick, being there over the phone, or providing support via distance platforms. All of those things are stressors that have been reported by people doing the work on the ground. Many workers have been isolated from their families and loved ones for an extended amount of time. And again, this is not just hospitals that are experiencing this. I know people who work in detoxes, for example, where people come into those detoxes for 3, 4, 5 days, and some of those people have made the decision not to stay at home with their families because they don't want to put their families at risk, but they also need the job, and they're committed to helping people with substance use disorders and mental health challenges. So, this isolation from families has an impact. Imagine for a moment that you were away from your family for an extended amount of time. I know what that feels like for me when I'm away from my family for 3, 4, 5 days at a time. People have experienced extended work shifts with little to no support. So some people working 12, 13, 15 hours, and the support hasn't been there because at the end of their shift, they're so exhausted. What they want to do is to crash and sleep, get up the next day and do it all over again with very little supervision, particularly clinical supervision that helps people cope with what they're dealing with. Trauma, grief, and loss. Here, we should recognize, take you back to May and June of 2020, when we saw the mass graves in New York live, right? And I don't know if you experienced this, but I went to a couple of drive-by funerals where, we couldn't necessarily speak with the families, congregate as we usually do, and provide support and help people process what's going on. And this has happened across the country and in many other parts of the world as well. The absence of rituals such as funerals, family gatherings, and opportunities for person-to-person goodbyes often results in disenfranchised grief. And this is happening across the country for many people, where right now some of those people are coming to a 1-year anniversary of having lost their loved ones, and they still haven't been able to gather to do some type of ceremony or bereavement process for their loved ones. This should be extremely concerning for all of us. For frontline healthcare workers, the huge surge in deaths is distressing. Discontinuing mechanical ventilation is emotionally onerous, with little time for mourning due to the intensifying situation. Imagine what that looks like. I know nurses and some doctors who have been present when people have died, and the one thing that they've been able to do for some people is hold their hands and hold up a tablet so that that person can speak to or just be in the presence of family members. I can't imagine what that looks like, because I too have experienced loss and I too have experienced grief. That is very difficult to do in normal times, normal in quotations, right? Imagine when you're not able to be with your loved one, right? Unusual and delayed grief may increase the risk of prolonged grief disorder in this pandemic. It already has, it will continue to do that. And those of us who work with mental health, substance use disorders, and other health conditions should be acutely aware of what that means for our practice moving forward, for our communities moving forward. We have, shifting here in terms of what our system looks like, we have a siloed and punitive system that has been created very specifically in the US. And so I'm going to speak to that siloed system and what has happened. Health, mental health, and substance use disorder systems are siloed. They still are. And in spaces and places where you might know, where they're working together more, good. I know some of those spaces and places too. But by and large, they are still siloed. Even within the same issue, they are siloed. Take, for example, substance use or substance misuse. Prevention, intervention, treatment, recovery supports. That's the continuum. In many cases, the prevention folk don't speak to the treatment folks. The treatment folks don't speak to the recovery support folk. And you know, the beat goes on in relationship to that. And these systems are not speaking to each other, what they do, and not collaborating with each other, what they in fact do is they sustain disparities, they create even more disparities, and they maintain the status quo, which is to say, it's more difficult for people to get better. What we've had in relationship very specifically to mental health and substance use disorder is a criminal justice response to a public health crisis. And we've had this criminal justice, what I call the criminal injustice response, for decades, We have institutionalized racism as a result and other forms of oppression that operate within these systems. And right now in the US, we're having conversations and we're doing a lot of work in this regard. And I, for one, who have dedicated my professional career to addressing issues of disparities and building equity, I'm very happy that we're finally having this conversation. And so the other thing that we have had is punitive approaches in treatment. So if you think about people with mental health and substance use disorders, or that they have co-occurring disorders, though many systems, what they have done traditionally and what they have done historically is that when you exhibit signs and symptoms of your disease, they have kicked you out or treated the people badly. Think about that. Someone has a substance use disorder and is in a treatment program, and they have symptoms of their disease. Those symptoms can include a reoccurrence, that people lie, that people steal, that people manipulate, that people have behaviors that are associated with the disease. And then the system kicks them out for exhibiting signs and symptoms of their disease. We don't do that for cancer. We don't do that for diabetes. We don't do that for any other health condition. And we certainly don't incarcerate people for those conditions either. But that is currently happening and continues to happen in the United States. Here's a piece that I like to call how we claim we treat people. This is the look inward to us as individuals. Have you heard the people who say I'm non-biased? I've said it before, I don't say it anymore. Have you heard the people who say they're non-judgmental? I've heard it before, I've said it before, I don't say it anymore. Have you heard the people say, I treat people as they come? I know where that comes from. I used to say it a great deal. I don't say that anymore. I treat people as we want to be treated, right? Treat people as I want to be treated. I used to say that a great deal. I've heard it before. I continue to hear it. I don't say it anymore. And my personal favorite is when people say, I treat everybody the same. All of this, and excuse my language here, is a huge crock of shit. Human beings are extremely biased. And if you don't own your biases, then there's nothing that you can do about them. There's nothing that you will do about them. But everyone learns bias, and we are extremely judgmental. Every single human being is. If you're sitting here in this webinar and you're saying, I'm not judgmental, you are, but I'm not, I will say that that is a judgment. You either agree or disagree with what I'm saying, that is a judgment. The reality is that when we combine bias with judgment, that is a recipe for disaster, and there's a lot of that to go around here in the US. Treating people as they come, listen, we are agents of change, and as soon as we meet with people, we go to what can I do to help you? We pull out the treatment plans, the recovery wellness plans, right? Whatever those things are, and we put in front of people rules and regulations that you will abide by being here in this place of treatment. So meeting people where they're at lasts for about 2 seconds. Treating people as I want to be treated, I don't do that because I am a 56-year-old Puerto Rican male. And not everybody that I come in contact with is a 56-year-old Puerto Rican male. And even if I'm working with a whole group of people who are 56-year-old Puerto Rican males, we're not all the same, which brings me to this idea of sameness. We're not all the same. We have similarities, but we have differences and unique needs. We have no business treating everybody the same. We don't value honesty, because if you go to a job interview and you say that you're biased, that you're judgmental, that you don't treat people as they come, that you don't even treat people as you want to be treated, and you don't treat everybody the same, you're not going to get hired. They're going to say, thank you very much for coming. We'll let you know. The reality is that we need a shift in perception and in reality in terms of how we treat people. Coming back to this piece on mass incarceration, in 1970 in the United States, there were 200,000 people incarcerated. Fast forward to 2021, there are 2.3 million people incarcerated in the US. If you add the 5 to 6 million individuals who are on probation, parole, and house arrest, this equals about 10 million people. We have the largest prison population per capita in the world. This is the opportunity for people to chant USA #1. This is horrifying. Largest prison population per capita in the world. There have been deliberate policies that created this situation. The deinstitutionalization, the war on drugs, the criminalization of behaviors, the sentencing regarding the differences between powder versus crack cocaine, mandatory minimums, no voting rights in up to 25 states, school zones where you get an additional 2 years of mandatory time, 3 strikes and you're out. There are cases in California alone, there were about 10,000 people sentenced with 3 strikes and you're out. There are a number of cases here in Massachusetts. One that was recently in the Boston Globe of a friend of mine who was sentenced to life in prison. His 3rd charge was that he stole a car. Really, life in prison for stealing a car? Think about that. Massive prison construction. And the reality is that many prisons and jails have been privatized and they're traded on the New York Stock Exchange. So you see the for-profit system coming into play here. And then the almighty criminal offender records that prohibit people from getting housing, jobs, and those sorts of things. If we add to this reality, and there are others, but if we add to this reality that at the federal level, 97% of all cases are pled out, so-called plea bargains. At the state level, all 94% of cases at the state level are plea bargains. This means that if you're awaiting trial, your lawyer, which is, if you're poor, will be a public defender, will come to you and say, the DA wants 20 years. Are you willing to take 5? The DA wants 5 years. Are you willing to take 2? The DA wants a year. Are you willing to take probation? And those are so-called plea bargains. And that is so-called due process in the United States. And these are majority poor people on the receiving end of this. And to prove the point, these are young male incarceration rates in 2019. And these are young males between the ages of 25 and 29. And this is per 100,000, per 100,000. So for whites, that's 1,437. For Latinos or Hispanics, that's 3,892. And then look at the rate for blacks in this country, 8,932 per 100,000. And no one on the face of the earth can convince me that black and brown people are more prone to violence and crimes than whites. As a matter of fact, the majority of people in prisons and jails in this country are white males, and they're poor white males, right? So what accounts for this? What accounts for this reality? It is those policies that I was talking about. So when people point to people like me and say, be more like Caner, he went to prison, he got a GED there, came out and got a PhD. The system doesn't work that way. I am an outlier. I am not the norm. I am the exception. So I refuse to come to places and just pat myself on the back and say, yeah, I did really great. If I did it, you can do it too. The system is rigged, and people of color pay a disproportionate price. upwards of 60% of people, depending on what research you read, who are in prison have a mental health issue. Upwards of 80%, depending on who you read. Here in the county in which I live in, it's 98%, have a substance use disorder, a diagnosable substance use disorder. So what we've done is we've taken a population that needs treatment and recovery supports, and we put them in jail. And we've created a system of profit that promotes recidivism and people coming back. To move into solution strategies, techniques, and partnerships moving forward, because I think that that's enough time in terms of talking about what the issues are, what the challenges are, and the reason why I brought in the criminal injustice system into play, it's because in my view, and this is not new to me and to others, in my view, we cannot talk about mental health, we cannot talk about substance use disorders without talking about mass incarceration. If we do that, we are doing a disservice to this issue and to the populations that we care for and that we're supposed to care for. And just think about for a second, these numbers that I give you here, let me go back for 1 second. Think about what COVID-19 looks like on the inside for these populations. Think about the isolation, the further isolation of people who are in prisons and jails all over the country and all over the world as it relates to COVID-19, and the disproportionate impact of these issues on those communities who are locked up, right? And on their families and on the people who have died out where they're, the people who are in jail can't see them, can't visit them, and the people who have died all alone in jail across the country as it relates to COVID-19 and other serious issues, right? So in terms of solutions, partnerships, strategies, techniques, and those sorts of things, let's get into some of those, right? I think that first and foremost, we need a process that moves us from dehumanization to humanization. And all of us, I argue, and it's there in the literature, in the research, if you want to read about it, we have been dehumanized to a certain degree. And if you don't believe that that is true, look inward. Have thoughts, negative thoughts around people experiencing mental health, substance use disorders, poverty, other challenging issues related to the societal determinants of health. Have thoughts come to your mind like they have come to mine, with pointing the finger at people and saying, if you want to get better, you can get better. This is just a matter of willpower and wanting to do it. Have you ever treated someone indifferently because they have a mental health issue or a substance use disorder, or because they don't, or have you seen them without a mask or without the proper social distancing, and have you thought about them in a way that's derogatory without understanding that condition, their reality, those sorts of things? Have you ever supported punitive issues around incarceration? Have you ever supported stigmatizing labels? Have you ever called someone an addict? Have you ever called someone a schizophrenic or someone bipolar? Have you ever even thought about that? I have thought about all of those things, and I have used that very language, even though I am a person in long-term recovery. And so what I need to do is to continue to look inward and to wrestle back my humanity, because this issue is a life and death issue. And I want to be on the side of strength, on the side of being a part of the solution. And somehow, some way, we need to do that at the individual level, at the family level, at the community level, and at the societal level, in terms of humanizing individuals who have been demonized, demonized and criminalized in this country. For me, that begins with this piece on cultural humility. And you can see here from the definition that cultural humility incorporates a lifelong commitment to self-evaluation and self-critique, and redressing the power imbalances in our relationships with the people that we serve. Notice that is self-critique, self-evaluation, lifelong commitment to doing that. We're moving away from these terms of cultural competency because many people have been to trainings on cultural competency, and what they get is a feeling that, oh, I already know everything there is to know around culture and around disparities and around equity, and that it's impossible to do that. I am a lifelong learner. I should be able to look inward and continue in that process. We should look to develop relationships that are mutually beneficial, non-paternalistic, and they should be based on advocacy partnerships with the people and communities that we serve. We should never come into communities with this idea, I'm here to save you. I'm here to save a life. I'm here to say, I don't save anybody's lives. I provide resources, support, information, guidance. People take control, families take control, communities take control of their own lives, and they do better. It is not about me coming in to save anybody. When we do that, it's an elitist way of doing things. And communities can read that in a heartbeat. Individuals can read that in a heartbeat. And so if we're moving away from cultural competency in that term competency, what are we moving towards? Cultural intelligence. It is the capability to relate and work effectively in culturally diverse situations. It goes above and beyond existing notions of cultural sensitivity and awareness, right? And we highlight a theoretically based set of capabilities, which means that we need to read research, data, information. We also need to immerse ourselves in communities that we serve. Too many people do drive-bys or come in parachutes into communities, and they don't have an understanding of what those community needs are because they don't live there and they don't spend time there. They don't spend their money there. And the model that we have is you come to me, I treat you in my setting under my conditions, and then you leave. And if something goes wrong with you, it's your fault, not mine. We need not to be just trauma informed. Being trauma informed is really important. I've been to a ton of trainings on being trauma informed, and rarely do I heard the social justice component to trauma, right? And we need to be social justice informed. And that means that we develop a lens of disparities, the societal determinants of health, and what equity means moving forward. We need to build equity. We need to build equity, and we need to focus on policies. The far left of the screen talks about equality. Equality lives in the minds of people with power and privilege. It doesn't exist. The objective here is to watch the ball game. When you look at reality, now the smallest person who couldn't see the game to begin with is now in a ditch. And I would argue that many people are born and relegated to that ditch until the time that they die. And for the person in the middle, things remain the same. And the person who didn't need a box to begin with now has 7 boxes. And by the way, for the person in that ditch, it's not just about personal responsibility and working hard, because if it was just for working hard, you would come out of that ditch. Every single woman in Africa would be a millionaire, a multimillionaire. So you can work really hard and still struggle and live in a life of poverty. I know people who work harder than I do. They work 2, 3 jobs, and they will never make in a day what I make in an hour. That is systemic. That is systemic. When we bring you to the middle and you look at equity, you look that now there's a redistribution of the boxes, redistribution of the boxes. But if you didn't question the fence, the problem here is not necessarily the boxes. We can chase boxes all we want, but the reality is that these people are on the outside looking in, and they're still marginalized, even with the boxes. So what we need is what? To remove the fence, and the fence represents policies, procedures, systemic racism, and other forms of oppression that don't allow for people to participate fully in society. So when you see images, such as the image that I showed you earlier, don't stop at the redistribution of boxes. Let's look at policies and procedures and deal with those. We need equitable access to COVID-19 vaccines and treatment. Yes, marginalized groups distrust government and healthcare institutions. We know why, and they have perfectly good reasons too. Tuskegee, smallpox for Native Americans, Tuskegee, syphilis for African Americans, the forced sterilization of Latina women, particularly Puerto Rican women in the US. All of those things make us distrust government institutions. All of those things do. But we shouldn't just focus on that, because that's, again, blaming the people in those conditions for things that they didn't do to themselves, right? So we need to focus on transforming racist and discriminatory systems. Don't just attempt to change individual beliefs and behaviors. We need system change, right? It's not enough to train people within an institution if the institution still has racist and discriminatory policies that have been institutionalized. We need to do away with those things. And we need to allocate resources equitably. And enough with this stuff around we can't reach people of color. Enough of that, because there's some of us who can reach them without a problem. Why is it that you have difficulties? And then you place the onus on communities and say, oh, those people don't trust us. Yeah, we don't. But we also trust people who are trustworthy. And so we need to partner with people who can do that. In terms of substance use disorders, I would be remiss if I don't mention this piece here. There is a lot of money going into healthcare institutions, including hospitals and health centers. There's a lot of money for substance use and mental health that are going into criminal justice systems, jails, prisons, police departments, sheriff departments, that sort of thing. And there's money that is going to community-based organizations who, by the way, have most of the experience in terms of how to treat people humanely, equitably, those sorts of things. But where is most of the money going to? Around substance use disorders specifically, it's going to criminal justice and healthcare settings. I am not arguing that they shouldn't get money. I am arguing that we should be more equitable in the distribution of that money, because criminal justice systems, as well as healthcare institutions, contributed to the problem. And now all of a sudden they're the experts, while community folk have been left out of those conversations. These things contribute to disparities. They contribute to disparities. And it's a single focus solution. If you pay attention to what's being funded, it's a single focus solution. What is that solution? Medication assisted treatment for everybody. Medication assisted treatment for everybody. And I am not against medication assisted treatment. I think it works. And I supervise a team of people, 2 teams of people who work with medication assisted treatment. But here's what we also know, that all credible evidence shows that there are multiple pathways of recovery. And so why are we hell-bent in putting one pathway in front of people and saying, this is what's going to work for you? And we have the evidence and the data to prove it. Of course you have the evidence and the data. It is because there's medication involved, the FDA, and you're required to collect that data. Very few individuals can collect data on 12-step, on faith-based, on exercise in recovery, on smart recovery, rational recovery. We fund treatment, but we don't fund evaluation of treatment, whether that's residential or outpatient, right? And so we need to embrace the multiple pathways of recovery and not just one single solution to this issue. We need to deal with the criminal injustice system, and we need restorative justice. It's not enough just to change policies while people continue to sit in jail. So for example, in Massachusetts, over $1 billion have been made from profits of recreational marijuana. Across the US, about 50,000 people still sit in jail for selling that same marijuana that is now being sold legally. And by the way, the people who own those companies are primarily white males, while people of color, and 2/3 of that 50,000 people are people of color, and they sit in jail. And people like me, who have criminal offender records, have criminal offender records for marijuana to this day. And so we need restorative justice. It's not just reforming or recreating a criminal justice system that works. It's dealing with past ailments of the system. We need true partnerships across systems, affordable housing, substance use disorder, training and employment, criminal justice, mental health, equitable education, faith-based, sports, recreation, and I'm sure that I left some of them out. But we need true partnerships if we're going to wrap our hands around the societal determinants of health. And at the center of this is government at the federal level, at the state level, and at the local level, combined with policies. Combined with policies. We know that advocacy works. We know that it works because we have been able to change policies and procedures. We have been able to impact policies that affect the greater good. And again, we need balance between saying to people, oh, we're just going to work at the individual level and that's going to make this issue go away. No, it is not. No, it is not. We need to transform systems. We need policies that affect the many and not just the few. And we need policies that are driven by understanding of disparities and the need to build equity. I want to thank you for listening. I know it's been a long talk. I have about 10 minutes left so that people can ask questions and or comments. Thank you very much. Angel. Hello, Angel, are you there?
Yeah, I'm not sure. I think he's having internet problems, so I'm just gonna go ahead.
Okay.
I'm reading through some comments that we've been receiving. Among them, they're thanking you for the presentation and the great testimony that you gave everyone. And someone affirmed that yes, the culture aspect in terms of like distrusting and that the fact that they are very afraid of the new vaccine. If anyone else want to go ahead and submit any questions or other comments.
Here's an opportunity to do that. Thank you, Cindy, for that. Let me say a couple of things about vaccine and a couple of additional things. I think that people are coming around. A lot of the people that I've spoken to, what they've said is, and I was in that camp in the beginning where I said, I'm not getting that vaccine first. Let other people go first. But right now, we need to continue to educate people because, again, over 525,000 people have died from COVID, right, from the virus, and many more will continue to die. And we need to say that, and in that same breath say, millions of people have been vaccinated thus far, and have there been side effects? Yes. Have people died? No. And so we need to continue to educate people. And I think that the partnerships that I was alluding to earlier have to be done in collaboration with community grassroots organizations, individuals that might be traditional organizations and non-traditional organizations. I'll give you a clue in terms of what's happening here in Massachusetts and a couple of missteps from my perspective. Like 2 large vaccination sites that the state opened up, one in Foxborough Stadium where the Patriots played, the New England Patriots, right? The football team, if you follow any of that stuff. And then the other one that was initially opened at the Red Sox Stadium, Fenway Stadium, that sort of thing. So those are the 2 large ones that were opened in the state. And then the people who started to go there were primarily white and not people of color. Why? Because, and then what was said is, oh, people of color don't trust us. That's part of the issue. But the other part is that you place these vaccine sites in places that are inaccessible and to a certain degree unfriendly to people of color. And so for me to get from here to Foxwood, to get to the stadium where the Patriots play, it's about 3 hours. And I have a car. I'm not going to do that. Imagine people who don't have a car, who lack public transportation, who lack the resources to be able to do that. We need to rethink that. We have sign up for vaccinations on a website that has crashed multiple times. And there have been advocates such as myself and others who've said, why do we need to continue to call to get on this site or to continue to log on when it's crashing? Why don't we just register and you call us when a appointment becomes available? Why do we have to wait? And there's a lot of people who don't have access to the technologies, to a computer. And if they have, many people don't even know how to use them. And you need to be on there for hours searching for a vaccine site that will give you an appointment. It doesn't make sense. It doesn't make sense. And unless we change those realities on the ground and partner with churches and community-based organizations and local groups who have trust within the community and bring the vaccine to the community, don't expect them to come to us. There are many people who are homebound. And so what does that look like, right? What does that look like? We need people to go to them. And there are models and examples of this working across the country in different ways. We just need to be committed to doing those. Do we have anything else, Cindy?
Yes. Oh my God. We have a couple, so I lost it. There was something really important that I wanted to read. And actually you have a Spanish comment, mil gracias por compartir tu historia, which means thank you for sharing as well. Mm-hmm. Some people are asking for more resources for them to engage on this topic.
Look at the resources slide that I just switched to. These are COVID-19 pandemic response resources for both the ATTCs and the prevention TTCs. This presentation, I'm sure, is going to be made available. These are live links. You can go there and or you can Google these and come across resources. I encourage you to look at resources at the local level as well, not just at the national level, but at the state level and at the local level.
And someone else shared, it's more of like a comment, and it says, I appreciated everything, but especially the perspective about MAT and other options for recovery. This brought up an issue for me as a researcher, that everything can't only be relied on as EBP because many, like you said, haven't been examined as EBPs.
Mm-hmm. Yep, and for those folks who don't understand that terminology, it's evidence-based models or evidence-based programs, those sort of things, right? And so, yeah, we don't have the data to say to speak to like 12-step processes, right? Or yoga and recovery, or meditation and recovery, acupuncture and recovery, all those holistic approaches. We don't evaluate those things, and so we don't have the data to say that they're evidence-based. It doesn't mean that they don't work. There are 23 million people who identify as being in recovery in the United States. And about 20% of them did that, are doing that with medications, which means that 80% have done it without medications. And as a matter of fact, people, not everybody needs treatment. And people who work in treatment get upset when I say that, but that is based on research. 12-step fellowships have helped millions of people all over the world. And 12-step fellowships is not treatment, it's recovery supports. And so people get better utilizing different pathways, and they get better with a combination of pathways. A lot of people go to church. As a matter of fact, many of my colleagues and friends don't call themselves being in recovery because their pathway is faith, and they don't believe that addiction is a disease, and they don't believe that they're going to have this disease for the rest of their lives. And when lay people and people who do research hear that, they get all bent out of shape. And you know what I do? I support people. Is that working for you? Yes, then good for you. Do more of that, whatever that is. You don't have to believe that addiction is a disease. You don't have to believe that, and they don't. what they've said to me is God lifted the obsession to use. God doesn't create imperfect beings in relationship to this, and I have been delivered, I have been saved. And I go, perfect, right? And so we need to embrace the multiple pathways truly, even if we don't understand or agree with them. Because the bottom line for me is not that you do things the way that I want you to do them, is that you do things the way that you want to do them that work for you. We should stop telling people what to do, how to do it, when to do it, because that doesn't work. That doesn't work. That has been the model that has been used in treatment in this country, where we impose pathways on people. And when they fail and they have a relapse or reoccurrence, then we blame them. My mom always taught me, Haned, every time you point the finger at other people, there are three fingers pointing back at you. Take a look at yourself. That's why I argue that we always need to look inward. I know that we are at 10 o'clock. I want to thank you for listening, for sharing your thoughts and comments. Muchas gracias por su participación. Nuevamente saludo a nuestra gente en Nicaragua y otra gente que habla español que está aquí en los Estados Unidos participando de este día. Que la pasen bien. Un abrazo solidario de mi parte. And I wish you well. Continue to stay safe. Thank you.
Gracias, Hunter. Thank you, Hunter.